to talk about neoadjuvant therapy in breast cancer in 2021. Clearly, over the last decade, we clearly recognize these four subtypes. I know there have been a lot of molecular stuff, but in clinic, we still go with ER, luminal A, B, HER2 positive, and triple negative breast cancer. And as far as the patient's journey is concerned, systemic treatment decision points are at the time of diagnosis whether the patient needs neoadjuvant therapy, the choice of adjuvant therapy, and the choice of extended adjuvant therapy. I am going to focus only on neoadjuvant therapy today, but I'm happy to take questions about adjuvant treatment as well. So the clear indications for neoadjuvant therapy, the surgical are to convert inoperable to operable, and also inoperable, but if you're not able to conserve the breast, to convert non-conservable to conservable. The medical indications are we want to test the biology of the tumor, provides prognostic information, especially the pathological complete response. It also creates an opportunity to modify and optimize the outcome, especially we can add agents to improve the pathological complete response. Or if the patients don't have a PAT-CR, which I will talk about in a minute, we can add additional adjuvant therapy, which we are doing now in triple negative and HER2 positive breast cancer. I think the key practical issues to consider before neoadjuvant therapy is to have a clear surgical plan documented, especially if any investigations like MRI has to be done, should be done beforehand. Assess the tumor-breast ratio. If breast conserving surgery is planned, do a baseline MRI. If feasible, clip the breast tumor. In this day and age, we should avoid doing a mastectomy if possible. Address the axilla, do an FNA before starting treatment, document if post neoadjuvant treatment, one needs to do an SLNB or axillary dissection. MRI is needed in lobular histology as well. If mastectomy is planned, very important to discuss psychological support and other things as well. And also with chemotherapy, one can discuss scalp cooling. Fertility preservation options are very important. We are seeing a lot of young women with breast cancer in India. I'm not sure what it is in Bangladesh, but seeing a lot of patients in India who are less than 40 years of age. In fact, when I was in London, the Northeast London, we had quite a few patients from Asian patients from Bangladesh and from India. And I was seeing quite a few patients who were less than 40 years of age. And at that time, we decided to form a young women with breast cancer registry. If any of you would like to participate, please let me know, because it's an online registry and we can collate the data together. So very important to discuss fertility preservation options and also discuss how one can prevent premature ovarian failure. So most of my patients get an LHRH analog before they start chemotherapy. The response to neoadjuvant chemotherapy could be that a unifocal tumor becomes multifocal. As you can see here, you may have a negative margin or a positive margin based on the surgery. You may have inconsistent responses due to multiclonality and heterogeneity. You could have no response, or you have a type 2 patchy response where you may end up having a positive margin, especially if the whole air footprint is not addressed. You may have an implosion with a type 1 response, or one can have a pathological complete response. I'll just go through the various modalities of neoadjuvant therapy. Chemotherapy is commonly used as neoadjuvant chemotherapy, but we must not forget that in ER-positive patients, there is a proportion of patients who may have a PAT-CR to endocrine treatment as well, though it is about 3%. So neoadjuvant treatment, I tend to use only in selected patients, which is older patients who have a strongly ER-PR positive tumor, and those who are not fit or they decline chemotherapy. The predictors of PAT-CR to neoadjuvant chemotherapy are, as you can see in all of these studies, mainly if patients have a hormone receptor negative tumor. So triple negative and HER2 positive tend to respond better than luminal B versus luminal A. and also the oncotype low recurrence score we are using now in neoadjuvant setting in some patients has a low PAT-CR rate. Anthracycline and taxane is the common best neoadjuvant treatment for all subtypes. And as you can see that the PAT-CR rate, if you add a taxane, increases from 13% to 26%. If we look at triple negative breast cancer, adding platinums to neoadjuvant chemotherapy also increases the pathological complete response rate. If you see from the JEPAR-6 trial, from 37% to 53%, which was about almost 20% more. And in the CLGB trial, it was 13% more with the addition of carboplatin. Bevacizumab made no difference. And there was a better 3-year disease-free survival as well in the JEPAR-6 trial. Coming to HER2-positive breast cancer, adding trastuzumab, as we see in the NOHA and the JEPAR Quattro study, increases the PAT-CR rate, actually doubles the pathological complete response rate with the addition of anti-HER2 therapy to the anthracycline and taxane-based regimens. The pivotal studies which have looked at addition of neoadjuvant dual anti-HER2 treatment, which is trastuzumab and pertuzumab, have been the NEOSPHERE and the TRIFINA study. TRIFINA study actually looked at the cardiac toxicity as well and showed us that it is safe to combine both the anti-HER2 treatments. As you can see, with the addition of dual anti-HER2 treatment, the pathological complete response does increase in HER2-positive patients. Summarizing, in triple-negative breast cancer, you can see that the pathological complete response has gone up to 50%. I have not discussed the immunotherapy in triple-negative breast cancer because of the controversy in the data in metastatic setting and in neoadjuvant setting. But yes, the study did show that the pathological complete response rates were 60% in PD-L1 positive patients. In HER2 positive, one can see that if you combine dual anti-HER2 treatment, the responses go up to as high as 60% pathological complete response. I'd like you to read this paper, which I was one of the co-authors in BMJ a couple of years ago. Neoadjuvant therapy is something for which patients need to be counseled adequately because of some of the data which is there. The EBCTCG analysis showed that the neoadjuvant treatment does increase breast-conserving surgery, but may increase the overall risk of recurrence. The downside of this study was that most of the regimens that were used in the olden days did not have taxanes and did not have anti-HER2 treatment. It had no effect on breast cancer mortality. The most important indication today in triple-negative and HER2-positive breast cancer is creating an opportunity to modify the treatment outcome during the adjuvant phase. And if we look at the CREATE-X study, for all patients who were HER2 negative, stage 1 to 3B breast cancer, patients after neoadjuvant chemotherapy surgery, those who did not have a PAT-CR were randomized to 6 months of capecitabine versus the control group. The arms were balanced and 40% of patients had stage 3A or B breast cancer, 32% had a triple-negative breast cancer. And as you can see that with the addition of capecitabine, the disease-free survival and the overall survival was significantly better in the bottom curves in those patients who had triple-negative breast cancer. And it is now standard of care for patients, those who do not have a pathological complete response after completion of neoadjuvant chemotherapy, to be offered capecitabine on completion of radiation if it is indicated. It does have its downsides with side effects, and we know that most Asian patients are not able to tolerate the doses that were used in this trial, which was 1,250 milligrams per meter square. Most of my patients are only able to tolerate 1,000 milligrams per meter square twice a day for day 1 to 14. The Catherine trial, also similar study, patients who had a non-PAT-CR post-trastuzumab-based treatment were randomized to trastuzumab continuation or TDM1. Nowadays, we use dual anti-HER2 therapy in neoadjuvant settings, so that this study has not answered that question. And as you can see, the invasive disease-free survival was significantly better for those patients who had TDM1, and the NICE has approved this in UK as well. Just a few slides on de-escalation of treatment. So we have stopped using 5-FU both in adjuvant setting, and we have extrapolated that to neoadjuvant setting, mainly because of these two studies, NSA-BP-B36, which randomized to FEC versus AC. And you can see the curves are literally on top of each other in node-negative breast cancer. So 5-FU just adds to the toxicity and is now no longer used. Even in node-positive breast cancer, FEC-PACLI versus EC-PACLI, you can see that, basically the curves are very similar in patients who did not have 5-FU. So even in node-positive, one can avoid using 5-FU. The other de-escalation is the phase 2 study, which is the Ptolemy study, where patients who are node negative but have a ER positive, less than 3 centimeter HER2 positive breast cancer, one can get away with weekly paclitaxel for 3 months instead of 6 months of chemotherapy, which we may recommend. To end, I would just like to show you a case which we treated, a 45-year-old lady who was diagnosed with breast cancer in December 2016, presented with a screen-detected abnormal area on right breast. Core biopsy was grade 2 IDC, ER positive, HER2 positive. The patient had a triple positive breast cancer. Though the mammogram showed a unifocal lesion, because the patient was young, we did an MRI breast. Because her breasts were dense, this showed that the patient had a multifocal lesion with about 4 areas, the total extent being 3.4 centimeter. So the lady started on ACTP regimen, and MRI had a very good response. As you can see, the pre and post MRI scan, the tumor had fully disappeared. She underwent a right mastectomy plus sentinel node biopsy and had a total path-CR. So there is good correlation between MRI complete response and pathological complete response. The only point I would try to make here is patients with ER-positive disease usually have a lower path-CR rate, as you will see in all these 5 trials, which had dual anti-HER2 therapy. But the path-CR rates in ER-negative patients range from almost 65 to 80%. But this patient was in the group which had an excellent pathological complete response. Can we identify a subgroup where we can avoid dual blockade? We still haven't answered that question. PATH-CR patients, do they still need 1 year of adjuvant trastuzumab, or can we get away with 6 months as we do with the Persephone trial in some patients? How I treat my patients is for triple negative, any patient more than T2 node positive gets dose-dense anthracycline followed by weekly paclitaxel carboplatin for 10 to 12 doses based on their tolerability. For T1, anything more than 5 millimeter patients do get adjuvant TC or AC times 4 or weekly paclitaxel times 12. Those who have a non-pathological complete response receive adjuvant capecitabine. HER2 positive patients, very similar, more than T2 node positive, get dose-dense anthracycline followed by TPH times 4. The use of docetaxel carboplatin is quite toxic with the febrile neutropenia rate of almost 30 to 40%. So I don't tend to use that. And adjuvant, we use again the same regimen, prefer dose weekly paclitaxel if patients can have it, and adjuvant trastuzumab for 17 doses. Duration of 6 months in node negative ER positive patients if there are resource limitations, and APT in small node negative ER positive patients. For ER positive, I use neoadjuvant chemo only for downstaging. Oncotype DX in intermediate risk, which we define by a Nottingham prognostic index of 3.4 to 5.4. And we do a comprehensive geriatric assessment. I think the rationale for neoadjuvant treatment in 2021 is mainly downsizing. And as default, if chemo is required, it would be better to offer as primary treatment. One can response assess every cycle of chemotherapy. The axillary conservation is still more controversial. We still don't have clear answers to this. Either we can clip the axilla or do sentinel node post-neoadjuvant chemotherapy. But the most important take home for me for neoadjuvant treatment is that it decides the adjuvant decision making in triple negative and HER2 positive breast cancer. Thank you.